Okay, good morning, everyone. Welcome to the webinar series of researchers in FAP. Today we are gonna be in the company of Dr. Glenn Callaghan. Dr. Glenn Callaghan, an early researcher on the mechanisms of change in FAP and development of FAP, of the assessments and coding system, discusses interpersonal behavior therapy, an evolution of ideas introduced by Kohlenberg and Tsai in 1991. So Dr. Glenn Callaghan is going to be presenting us further developments in IBT. So it's going to be really exciting to hear from you as one of the main developers of this model and like hearing about your proposals relating functional idiographic assessment template, the FIAT2. So welcome, Glenn, and we are all yours.
Thank you so much. Let me share this little presentation I put together, and then we can have more of a conversation. Here, have more of a conversation on.
We are watching just. Okay.
Yeah, sorry. So we'll put that into full screen. Great. And then. Did it turn the camera off? I apologize. I can't see it now. I can only see this.
Yeah, we can see your face.
Great. Wonderful. Well, thank you so much for asking me to share some of these ideas in this presentation. And so this is, as you had mentioned, it's an evolution of the 1991 version of FAP and kind of a return to clinical behavior analysis. And so we can also talk about why the name is not just, FAP or FAP version 2 or something like that. Some of that I'll chat about, but I have a few slides just to share kind of this evolution process and then what the model is and also how it's tied, as you had mentioned, to the assessment system that you mentioned called the FIAT. So interpersonal behavior therapy is something Bill Follett from the University of Nevada and I kind of coined as an extension to the 1991 book by Kohlenberg and Tsai, and then all of the research that has followed by you and me and other people, trying to really document the mechanism change, trying to, specify that, develop ways to assess for client behavior that would make FAP more consistent, and also help develop a more programmatic line of research. And so what it does, and that article sort of sketches out the very first pass of this evolution, is really focus on behavioral principles. And so, of course, the 1991 book introduced those. It was much more accessible than purely clinical behavior analysis book. And as FAP evolved, particularly here in the United States, it began to focus on dissemination and efforts to not maybe be as caught in the behavior analytic language that we saw as central to the value of FAP, particularly through the 1990s and early 2000s. And so that return to behavioral principles then focuses really on specifying the mechanism of action and the mechanism of clinical change, which is differential social reinforcement of approximations towards improvements. There's not really anything fancy there. It's just shaping more effective behavior. And the target, of course, with this therapy is interpersonal behaviors. And the interesting thing when you start to look at the evolution of clinical behavior analysis and how that's impacted at least a big part of, for example, acceptance and commitment therapy, that evolution of behavior and clinical behavior analysis starts to really talk about, well, what is going on with the process of intrapersonal experience? And when we lift up and we look at, well, what is happening when I experience a feeling, when I share a feeling with others, is that's I don't doubt that that's an experience that we're having privately, that we're having intrapersonally. But the expression of that is entirely social. And so when we talk about the experience and expression of feelings, what we're talking about largely is a socially constructed experience, at least reinforced in terms of how it is expressed, how people respond to that. So I'm not saying that my feelings are constructed by you. I think I feel what I feel. But the expression of those, the only real way we know those are manifested, quite honestly, is through the social engagement. And so I think this clinical behavior analysis that's allowed this really neat evolution of psychological experiences that are intrapersonal. Now I think we can let that sort of start to reach out over FAP and allow a behavior analysis of these complex behaviors that aren't just intrapersonal but are interpersonal. For me, it's certainly, I think, relational frame theory and the extensions of that by Barnes Holmes and colleagues would apply here. But because a lot of this is more public behavior, we can also utilize very basic behavioral principles, like successive approximation of change, the reinforcement of that. Anyway, so this evolution sort of tries to really shove FAP back into clinical behavior analysis, and when we did that, what occurred to me in particular is that then you're starting to look at a different unit of analysis. That unit of analysis is the interpersonal dynamic interaction between the client and other. It's not just the client's experience, it's actually the client, and it's not just the client's behavior, it's the client's behavior in a context. So this is consistent with contextual behavioral interventions or contextual behavioral science. And so in that, and I'll sort of show you a small little illustration of this, that dynamic interpersonal interaction that has to include another person. And so what that does is broadens our conceptualization to not only include the client, but the reinforcing properties, the behaviors of those outside in the community. And this allows for, I think, a greater precision, the clinical behavior analysis, the targeting of specific behaviors, but also where's the behavior going and who might be reinforcing that besides the therapist in the room, who is also in that dynamic interpersonal interaction. And I think then what it allows, and this is something I would love to talk about with people, is that precision that clinical behavior analysis brings and that set of behavioral principles actually allows a deeper precision of training. Because one of the challenges, I think, of FAP is that it's quite, and I'll use this term very, very playfully, it's quite magical to be in the room with people and to allow them to express and behave, and then to use social reinforcement, to use what's going on in that therapeutic relationship to affect clinical change. So it would allow a precision not only of instruction and training, but also a precision in what it is we think we're assessing and targeting in clinical work. And then, because it's grounded in behavioral principles and behavioral science, that it would actually help us refine an agenda and program for scientific investigation that I think is continued in lots of places around the world. But we would ideally then create this more organized, coherent agenda of science that's about investigating these principles, not middle-level terms or other challenging, abstracted descriptions of what it is we think we're studying. So Amanda, is it useful if I continue with just a couple other kind of slides and ideas?
Yes, please.
Awesome. Okay, so for me, I like to write a lot of words, but sometimes it's also easier just to think of this in pictures. And so here's what I'm trying to say IBT is and how it connects to the FIAT, which we'll get to in a second here, which is the functional idiographic assessment template, one way of organizing how we think about client behaviors, and by extension, community members' behaviors and the therapist behaviors. And so so we'll talk about this way of approaching the assessment of client behaviors that actually bridges the functional assessment process to what it is we're specifically targeting. So our core unit of analysis is this dynamic interpersonal interaction. We're looking at in FAP, in IBT, a way to help clients have more effective relationships. Arguably, for me, a way to have clients behave more effectively, and given that we behave as this primate, we behave with others, then necessarily the unit of analysis is the dynamic interpersonal interaction. So there are two people. At the very basic level, there's the client and there's someone else, and they interact. And so the client behaves as a speaker, as someone who's talking and behaving towards others, and the client also acts as a listener, responding to others. And so we can talk about behavior towards and responding to. We can talk about speaker and listener behavior, as long as we use that speaker and listener in the much more behavior analytic sense of these are very active roles. This is not passive listening. This is engaging in response to others. And the same goes actually then when we look at what's going on with the other person, that the other person is acting as a speaker, behaving towards the client. The other person is acting as a listener, responding to the client. So if we think about the client doing something like sharing a feeling, they can act as speaker and express that feeling towards somebody else. I feel sad. I feel joy. But they also then act as a listener, and there's a skill set in responding to listeners, or to the other person, as a listener. So I can listen to someone's expression of sadness and respond to that. I can listen to someone's expression of joy and respond to that. And that key feature here is that this is a reciprocal dynamic interaction. That it isn't enough for me to shape up for the client their ability to act as speaker. It's actually essential for me to also make sure that they have the repertoire for responding as listener. So I can express my needs towards someone else. What is it I need in a moment or in a relationship? But I also need to be able to respond to other people's needs. And when we shift that over to who in the community is doing this, or the therapist, because in the therapeutic relationship, in this clinical session, that therapist is other. That therapist is the other person in this dynamic interpersonal interaction. So we ask if the client is working on, for example, expressing needs, what they need from someone else, either in a moment or in a broader relationship. When we look at that, we're asking, well, how do other people do that with the client? And importantly, arguably, I think for our clinical work, one of the most important things is how will they respond when the client asks them for something they need? Or how will someone else respond to the client when the client expresses a feeling like sadness or joy? And so what we're saying in IBT is it isn't just us working with the client, it's actually us looking at two people who are engaged in two roles. It's not just the work that we do helping the client to learn how to more effectively, share an experience. It's actually how do they respond to others when others share experiences, but also how does the community express and share experiences and respond to the client when they do that. So there's always two people and they're engaged in these two roles. And then the assumption that I have then is that human suffering, behavioral challenges, behavioral skills problems, and the remedy of those occur in this space, in this dynamic interpersonal interaction. So ultimately what we have then is we have these two people who are in two roles. And for example, we have the client who engages as speaker and listener, and so we assess the client. And while we don't have direct access to all of the people outside, we do want to roughly assess who are these key players who engage in these roles as speaker and listener to the client, as someone who responds to and reinforces behavior or prompts behavior by the client. Who are these people, and can we create an assessment of the community members that are key for the client's behavior change, as well as the therapist? And as some people know, there was a manual that corresponded to the fiat that was called the facet, or is called the facet, that looks at therapist behaviors. And so this is basically the same thing, except we've sort of radically shifted how we talk about, well, I don't know if it's radical, but we've shifted how we talk about some of the stuff in the fiat. And so I don't know if you need a separate fiat at this point for therapists. The conceptualization of the therapist repertoire is still fundamental, but they're fundamental in as much as everybody else is, possibly more so because they have a bit more power in this moment, but they're still just someone as part of the dynamic interpersonal interaction. Okay, so central themes of IBT. The unit of analysis is this dynamic interpersonal interaction. The mechanism of change is still, I would argue, from the early stuff that got set down in the 1990s, the mechanism of change is still differential social reinforcement of more effective behaviors or approximations to those behaviors. But now the mechanism of change exists not just inside, but our goal is to try to target and track it outside. Not the descriptions of behaviors the client should engage in, or the functional relations of those behaviors as they may occur outside, but actually that we identify where and when that might better occur, where and when the client probably shouldn't do this stuff with the client, but also to find out what happens when they do those behaviors outside. And so this requires, and this is one of the parts that I'm most interested in talking about, because this has been kind of my push for a really long time. But I think once you sort of announce this, that this is about this unique client's interpersonal, this dynamic interpersonal interaction that occurs with others, that it would require fundamentally an idiographic case conceptualization, that this, no matter what, is going to be unique, that there cannot be any one single expression of something like behavior that's under competing control of contingencies, or control of competing contingencies, probably the right way to say that. That we might call courage. There is no one way of expressing that it would, of course, vary massively and tremendously by the individual. And that idiographic conceptualization, as we return to clinical behavior analysis, is based on a functional assessment. And functional assessment, there's lots of different ways to talk about how to do those. I can talk a little bit about how we've kind of developed ideas around functional assessment. But also, once you narrow the repertoire of interest, the target repertoire that occurs under antecedent and consequential control, once you start focusing on that repertoire, those repertoires of interest, that we then specify those client behaviors with basically with more precision that actually would direct us for what we would look at for this client to change and how we would know if it changed. And so one of the cool things about this is that we're examining not only the behavior of the client, but what are the functional, representative, verbal social reinforcers that actually are occurring out in the community, and can the therapist sort of line up with those? Can the therapist apply those, or will they be different? So as the therapist applies representative, functional reinforcers that are more likely occurring in the client's environment. So these are natural, but more than just in the way Förster had talked about, and Kohlenberg and Tsai have talked about, well, I guess we've all talked about, that natural reinforcers are non-arbitrary, meaning they're functional and they're not just what therapists say. But actually the therapist, I think we have an obligation to find out, well, what are the reinforcers that are occurring in the community? How different are those reinforcers that occur in the session, which may also be functional, but would become potentially less representative of what we're sending the client out to receive out in the community. I think what's really great about this is it helps situate this part of FAP IBT into a much more contemporary focus on cultural variables or contextual variables that occur in the community, that we think about, what are those community defined, as Vandenberg and colleagues have talked about, what are those reinforcers that are actually defined by the community that functionally impact client behavior? And as I work with the client to help change those behaviors, what actually is the community looking to reinforce? And when they do that, how does that look? And if I start applying very different reinforcers in the room, even if they became functional, that is, that they actually help change behavior in the room, notice that they may be so different than outside the room that they may not, the client may become less sensitive to those contingencies. And this creates interesting challenges, there's no doubt. But I think pointing to this helps situate us in this contemporary focus and necessary focus on cultural and contextual variables. So just a couple more slides and then we can stop and see what else would be fun to talk about. Is this use of assessment and the fiat and the version of the fiat now that we have that isn't published but we're writing up. And I'm happy to send ideas if people are interested in hearing about this. But the fiat, the functional idiographic, right? So functional, looking at ideally the actual function of behavior, understood in a three-term minimally contingency analysis. And the assessment then is of the client behavior, but also of the community members. And the template is, this is just a way of talking and ideally is helpful. And it's a way that we can say, this is what we've seen in lots of clients. Does some of this apply to your client? But it won't all apply. So it's more of a template. It's not a, you got to do it like this and they're all going to have these problems or something. But the idea is that it's going to assist and the functional assessment and narrow those targets. And so we conduct a functional assessment. We listen to what's going on for the client as they talk to us. We watch in session. What are the behaviors of interest and what's occasioning those? What are those antecedent or setting conditions that give rise to these behaviors? And what is the behavior of interest? What are we seeing here? And we can go to the fiat categories that I'll show you here in a second and say, does it kind of line up here? And if it does specifically, if the client's struggling with expressing a feeling, if the client's struggling with identifying and experiencing and engaging conflict and moving towards compromise, what specifically about that conflict and compromise is challenging for the client? And so the fiat then creates these targets for behavior change in that dynamic idiographic conceptualization, knowing that the client is engaged in two roles and that there are always two people. There's the client and there's the community members, there's the therapist. But the fiat focuses then across these 5 classes or response classes of behaviors and starts to narrow those behaviors into contingency skills. And contingency skills is our fancy way of saying, like the fiat one had, there are these contextual cues, discriminative stimulus conditions that we want the client to be able to recognize. And then there's the response repertoire, but there's also the client's kind of reception to and discrimination of contingencies that follow that behavior, consequences, basically. So we, again, there's lots of ways to do a functional assessment. We watch, we listen, we ask questions, we ask about what goes on outside, how that's similar to what we've seen inside. We ask where the client sees their challenges. We can also ask about, do they have problems in areas that they haven't talked about? We can use the fiat as categories of those kinds of responses. And we're looking for, what are the antecedent conditions that give rise to this behavior? The client can't express a feeling. Well, there's a lot of antecedents. There is the intrapersonal experience antecedent of, do they recognize a feeling while it's happening? Could they name that? Do they recognize the context of when, where, with whom they may more likely feel that or express that? There's the behavior of interest. What is it that they're doing or not doing, or what skill do they have or not have intact? And then there's also the consequence, functional consequence of what happens when they express this feeling. How do others respond? Does it facilitate their goals of interpersonal connection or some more instrumental goal of expressing that feeling? That points us to the repertoire of the community. Does the community have a repertoire or a skill set to reinforce that? Is that valued by the community? And so that response repertoire, as we think about what are the contingencies that give rise to this behavior, that occasion this behavior, what are the consequences that follow this behavior? And we could talk about motivating operations here too. I'm sticking to the 3 terms because it makes it a little bit more simple to kick off towards what's about to get more complicated with the fiat 2, although the fiat, in fairness, has its own complications. So we use the fiat to specify those response repertoires in the SDR, SR, or the ABC, the behaviors that we're talking about. And we have these 5 response classes in the FAP-2. Are they functional? I mean, they are on paper, but as we describe them, we start listing out topographies. Those won't line up with each client, but they're just examples. But there are different functions in me engaging conflict and resolving that potentially than there are in me naming a feeling, or asking for what I need. But naming a feeling and asking for what I need may give rise to conflict. These response classes aren't orthogonal. They aren't separate. They're going to overlap. And I think there's going to be multiple ones occurring in different client behaviors. I think that does pose challenges. I recognize that. What I would say, though, is that also sounds like the real world and real human behavior. And my goal in evolving the FAP-2 in particular, but also connecting it to IBT, is to have this line up with and map onto the real world of what we see with clients. And so these response classes, then, we can talk about specific skills, where these line up with the ABCs, the stimulus, response, and consequences of a functional assessment, but these are actually all skills. So if I go to express a feeling, can I recognize that I have a feeling? Can I name that? Can I discriminate that feeling? Can I discriminate where, with whom, and when it might make more sense to express that? If I have a response, is that response more of an excess? And I share the feeling when it's like, rah, it's huge. And the functional consequence, if we go back to our functional assessment, it's like people heard that you expressed feeling or I expressed feeling. But they're not going to really reinforce that. They may, in fact, put it on extinction, drift away, or even punish the expression because it's sort of aggressive or excessive. Is it a deficit? Is it, and so on. So the response skills we can talk about, particularly, and the same with the consequence skills that we think of as consequence reception. Does the client recognize, orient to, that there are consequences that follow their behavior? Does the client then discriminate what the impact is on the other person when they behave? Can they discriminate what the consequence was that followed their behavior? And this all goes towards others as well. So again, we don't have access to others the way we do with clients, but we could think about, do other people recognize opportunities to respond to or express to the client what they're feeling or what they're seeing with conflict, or an opportunity to disclose or share an experience? When they do that, what does it look like? If the client were to share a feeling or discuss some event that happened to them, sharing kind of a personal experience, how do other people respond to that? How does that impact the client? And so ultimately, you end up with the FAP with these categories of assertion and our ability to respond to feedback and impact that we have on others as well as that they have on us, conflict that's expressed or engaged in mutually or by one or both members, and a movement towards compromise, our disclosure of experience, and our expression of emotions. So we have 2 people engaged in 2 roles in 5 classes, and then these skills, and this is way too much to think about, right? So this happens with both members, right? With the client asserting towards others, responding to the assertion by others, others asserting towards the client, others responding to the client. And I think FAP would focus then historically mostly on this and this, but less on other and more on what it's doing to the client. And this is just by way of saying that then we have these antecedent, detection, discrimination skills, response skills, and consequence skills that are in the FAP-2. And they're all the same for each of the response classes. They would vary, of course, by what the response class is about. But one of the things I'll highlight here is the goal of all the response skills is to create these broad, flexible, generative repertoires. That what we want for the client is to be able to certainly, as a response, in the expression of a feeling or in the assertion of a need, or the response to someone else's assertion, or the response to someone else's need, is a repertoire that isn't rigid and fixed, but in fact has kind of multiple varying topographies of the response. That it is flexible, that if one way of responding doesn't work, they try another way of responding. And then it's also generative, that they become creative. They cobble together pieces of repertoires, that they create a different way of doing something if that's what is useful in the moment. And so the goals of the antecedents, these pro-social skills, are what we're looking for of the antecedent detection skills, of response skills, of consequence reception skills. And then we can see kind of here's where some of the way problems might show up for clients, that they may have less ability to discriminate, when, where, with whom. They may more effectively engage in this behavior. They may only do it with certain people. They may actually do it with too many people. They may be discriminating things in moments because of histories that are very, very vigilant and hyper kind of tuned, that may then lead also to a more rigid response. So when we do IBT, what we're doing in session is using the fiat to target, behavior for change, differentially reinforce target behaviors. We evoke, we respond to the occurrence of those behaviors. When the problems occur, we determine whether the client has kind of discriminated what it is they kind of want to have happen, what Bill Follett and I talk about with behaving with intention. What is it right now you want to have happen? And they check the discrimination of that context. And we help them then discriminate what they want to have happen, trying different ways to have that happen, discriminating consequences of that in the moment, so that you can do this live in vivo differential reinforcement of client behave. And if we provide aversive responses to that, we always prompt approximations, right? We say, well, I don't think that's working. I don't think, I feel disconnected from that, or I'm not able to really kind of be brought into that and help you in the way I think you want help. But we then prompt, what else could you do? Given that's what you want to have happen, what else could you try? And then we see whether or not the behavior that we just engaged in, if let's say that they try something different and they've tried something that's effective, or they naturally just do, something really effective in session, and we reinforce that, we always check to see if our behavior actually functions as a reinforcer. Certainly by watching to see if the behavior occurs more spontaneously, more on its own in session, or even prompted, that the more effective repertoire occurs. But also, how are they describing the behavior going on outside? And so not only was our response functional, but representative sufficiently to allow the behavior to occur outside. And so as we extend that behavior into the community, that we don't just differentially reinforce stuff that happens in session, that differential reinforcement of target behavior, we're trying to move outside using those targets of behavior change in the fiat. No one's required to use the fiat. It's always free, so people can use it, but they just have to be specific, right? So fiat or other specified targets of behavior change. And so what we're looking for then is this ability to assess roughly what are the people outside in the community doing as they behave towards and in response to, as speaker or as listener, to the client. And we can identify then target members and their behaviors in the community that may more likely reinforce client behaviors or prompt behaviors, and less likely extinguish or even punish emerging client repertoires. Of course, we're always assessing for safety for the client. So not just will they be aversive and possibly, punish client behaviors? Might they extinguish these because they're not interested in them, or put them on extinction, I guess we should say. But also, are they safe people with whom the client may interact, whether they're standard continuing members of a community or newer members of a community? And so we have the client engage in those behaviors and they report back to us. My hope is technology will emerge with sophistication of keeping track of some of this, not to monitor the client, but to have them maybe self-report even closer to an event or real time when their behavior is improving in a direction that they value, that they want behavior change to occur. And so we're talking about the functional reinforcement that occurs in the community. We can troubleshoot problems where the behavior doesn't extend very easily or well. And we're tracking changes. And this comes back around to our programmatic science. I think we track changes of client behavior. We can use things like the FAP or other categorizations to talk about the functional reinforcement, the differential reinforcement of more effective behaviors, and pull that science together, I think, in a way that we saw ABA do in early work with autism, that was all idiographically driven, but functionally tracked to show that what they did created more effective target behaviors. We have a lot more behaviors potentially, or more abstracted behaviors. There's complications here with the population of clinical behavior analysis and applied behavior analysis, but I think this is possible. And we look for in-session changes as that behavior translates and generalizes actually from change that happens there into our session. And we track that. So I think that's probably the best place to pause. I'm going to stop share here. We got other things we can talk about. I'm going to minimize. And we can maximize this, I suppose.
Okay. I think that you are still sharing your screen. Okay, it's off. Well, thank you so much, Lynn. I have a couple of comments on the chat. Let me read it.
Yeah, please. Sorry if I talk too long there. I just get so excited about this stuff.
No worries. I love it. I think that people really want to know more about this model and the proposal. So yeah, it's exciting. So one of the persons said, I really like how IBT keeps close to the basic principles of behaviors and seems to be clinically applicable to assess complex behavior. I work with DBT to adolescents and like these perspectives. So how you can link the work of IBT with the work on DBT, for instance? Do you have any?
That's awesome. First, thank you so much for the kind words. That's always super helpful because I just sort of work on this by myself a lot of times. And then I would say, so hopefully this will make sense. I think that our agendas are very similar in DBT and IBT or FAP. They're actually very similar with ACT. It's just that the target in ACT is much, much more intrapersonal. But I would argue, and I think I'm certain Robin Walser and other wonderful people in Jen Gregg in ACT would talk about that fundamentally that intrapersonal experience occurs with others. What DBT does so well is it always talks about both. It's about emotions with people and our ability to, I think, behave more effectively. So the two pieces I would say there are, if something like, certainly a functional assessment in DBT, but if something like, a categorization of kinds of behaviors people struggle with that are represented in the FIA are useful for developing skills with clients in DBT, then that would be wonderful to use if it brought a specificity. What I will say, and it wasn't in the slides, but FAP, I would argue, and IBT explicitly kind of sets its limits on who we can work with most effectively. And those limits are trying to think of how to say this most clearly, are on more established basic repertoires of verbal regulation and emotional regulation. And while I had spent a long time in my career working with what a long time ago, and I don't think this language is consistent anymore, Marsha Linehan talked about as stage 2 DBT, that is people who had got the basic skills, and then I started working with like, okay, how do we connect you? That those who were, this is the language I would use, and I hope it doesn't sound disrespectful because these were my people, clients who were chaotically emotionally dysregulated, meaning they would have a feeling and just become kind of undone by the intensity of that, which makes perfect sense given their histories, their inability to respond to it, to express it in a way that probably wasn't either punished or just responded to with craziness. And so as they have those feelings, we need to bring those amazing skills in DBT of emotional regulation to help establish them as someone who is more emotionally regulated, who then can go out in the world and try to share a feeling, which is a mess of an experience. And then if someone responds like, I don't understand that, and that's weird, that they can say, okay, and that's painful, but let me try again, or let me think about how to do that differently, rather than maybe triggered into a very intense dysregulated response. So what I'm saying there about DBT is almost like, again, maybe it's just because I was trained this way, is like, let's give them the ground floor in DBT. And what I would love is then FAP and DBT become one thing. And we're still working on those basic skills, but the kinds of emotional expression skills that are talked about in the fiat are much, what do I want to say, kind of more sophisticated, well-established skills, where, like we're saying, not that they know how, clients know how to recognize all their feelings or even experience those, bail out of them. That points to two different skill sets. Can you name it? Can you recognize it? But also, can you experience it? Very acty. Can you experience it? But notice that that question of can you experience it presupposes that that's possible. And I think people with different histories sometimes can't because that experience is embedded in such a rich history of trauma sometimes. Or the radical experience of emotional sensitivity that some of us are just born with and that needed a learning environment to help have that experience. That it's almost like schools kind of just teach to the average student, and some students need different kinds of help. In the same way, I would argue, and this doesn't apply to DBT, but IBT FAP isn't for profoundly non-verbally regulated, or what I think Dermot Barnes-Holmes called verbally sophisticated humans, right? So we don't do straight up this kind of IBT or FAP with people who may be more deep on the autism spectrum or who don't respond to social contingencies in a way that many, many people do. Not that you couldn't use the principles, and of course functional assessment is, functional analysis, I guess we would argue for ABA, is fundamental. But those are kind of the two resting places. And then as I would say with DBT, as soon as we get some regulation, let's bring in that social behavior. But we need that regulation. Hopefully that wasn't too long-winded and made sense.
No, not at all. I actually, that language is still working on DBT, the step 2 and step 1.
Oh, okay, cool. Yeah,
well,
I know it's grown up. Since I was so fortunate to Marsha would come to Reno with these little things introducing ACT, and Bob would be there, and you get to hear Marsha talk in person. She's oh my gosh, this is amazing. And then you start to realize like, oh, we're working with different populations. Not really, but basic skills. Yeah.
And while I still in Reno, it still happens, this phenomenon of the DBT team, once the person pass the stage 1 and like learn all these beautiful ways of stay alive.
Yes.
And they were kind of moved to FAP.
Yep.
for developing all these other important skills of social interactions, because like the protocol of Marsha is pretty much centered in some skills for assessing needs and discriminating like safe relationships and like kind of discriminating what kind of things you can do for making different a relationship, but not in the fine grain that
That's it. That's the way to say it. Is there's this more kind of basic fundamental discriminations and repertoire, and then I don't see FAP as only being for, you know, high sophisticated people in that, but it's a step above that ground level. And then,
yeah.
okay, so we've got that. Now, how do we get you feeling really vital and connected? You know, and for different people with different histories, there may be different levels, different amounts of that is probably possible, at least early on.
Yeah, totally.
Yeah.
Yeah, I can see the connection too.
Yeah.
So I was, while I was listening to you, I was also thinking about how you imagine a research agenda on IBT, because the complexity of the dynamic is something that and I think that many of us have struggled with, like how we
Yeah.
can capture that.
Right. So that's awesome. And I don't totally know you know, how that's gonna look. Here's what I can say. I'm gonna look at a couple of the slides that I wrote because I anticipated this. That there are layers of the research program, and here's where I'm excited and also recognize, like, oh, this is complicated. This is trouble. What I'm excited by is that this looks more like, I don't even know if I'm going to use this term right. This looks more like a natural science to me. This looks like something that is really trying to look at what actually happens in the world. And you know, in a neat way, you know, Hayes and Wilson and Strassel and Walser and all these people who help build ACT were looking at one of the most complicated things that humans do, which is to think and feel. And they created a science that's trying to understand that. And so I think the invitation is there for us with FAP, IBT. And again, the distinction I'm making is like this grounding in behavior analysis, like that as FAP disseminated, again, particularly here, it's left some of those, not that you have, not that I have, but sort of a callback to this. And that as we do that, then we can say, well, let's bring that to bear on these really difficult problems of a dynamic interaction and start to break those down, knowing that as you break it down, you're going to lose the gestalt of the whole potentially, but you're still trying to talk about it. So when we create client behavior change in session, that the therapist is fundamentally part of that unit of analysis, not just we should also do a conceptualization of therapist skills. And that the other is even more important in some ways than the therapist because of the sustainability of behavior change in the community, right? Not just the therapist. So what I would say is we keep going as a program of research, we keep going with looking at, is there differential reinforcement of client behaviors happening in session? Can we target where, when, potentially how-ish those behaviors might be reinforced outside? Can we track change? Can we track even an opportunity to show that those behaviors occurred outside and, I mean, functionally, if they keep going, they are reinforced, but that the client detected the occurrence of a consequence, that consequence could be sort of roughly documented, and you could see if these behaviors continued. So we sort of, we create this way of trying to look at the mechanism of change, both inside and outside, still continuing to try to refine that. We try to document that outside of session, that we show a value of the assessment of community members outside of session. I mean, I think that some of the research could even start there. Is there even a utility of this? Like, this is a proposal. This is what I tend to do and work with clients. It's how I teach people to do their work with clients. We might show, I don't think this is really done. It's not done in FAP. I don't think it's really done in psychotherapy, quite honestly, very well across paradigms, is that we show this value of creating a conceptualization of therapist behavior and document therapist change over time. This we have the technology for. It's a pain in the butt, but I think that might be useful, that we could show behavior change or skills development of a therapist as a function of supervision. And so what we're doing is trying to document that. I think the general agenda is, can you identify where things work and don't work in an interpersonal interaction? Given that it's two people, you got to look at both skill sets. Can you show that one person is able to change those behaviors? Is there a usefulness in that assessment? And does the behavior change continue? And then we in concert with that, look at, is the mechanism of change happening? Are there approximations or proxies that would suggest that that is happening? In the same way, and I'm speaking out of my field here, but if we did an applied behavior analysis, functional analysis of a child with, self-injurious behaviors on the autism spectrum, could you show the differential reinforcement of more effective behaviors happens with the ABA trainer? And does that extend when the ABA trainer isn't there with the parents? And what do the parents do? Do the parents actually continue that same DRO, or are they doing something different? And those become rougher approximate. I mean, I think you can track, you can put a monitor in, it's a different population. Like, we're struggling with really hard populations. These are free-range chickens, right? They're all monkeys running around. And so we're trying to keep track of these primates and really complex behaviors. So I do think it's challenging, just like you said. I think the other challenge, if I can just say this, and I'll try to shut it up, is this requires us to really examine the science of human behavior. I think, the difficulty of clinical behavior analysis, as it has risen with kind of the movement of the empirically supported therapies process and evidence-based models. And I think Hayes and Hoffman and some people are really, and Joe Cherokee, I think, are really on the idea of this. I think we would differ on where it's going, but that evidence-based can start to look at principles. Like, oh yeah. I think they're looking at methods. And so I disagree with that part, but they're looking at like, let's talk about how you could gather evidence for these things we know might work and as we apply them. And so that's rethinking science a little bit. Not like, this client has this problem, so you give this treatment and you show that that works, and that's empirically supported treatment. And I think it's wrong-headed. And instead, we want a science that can say, for this unique individual, how do we use principles to apply change to show the change as it would be meaningful for that unique individual? And is there a way to gather those data? And I think there are. But it's a more complicated science because it's not the average client with the average problem treated by the average therapist. And as you said, it brings in multiple variables. That dynamic means that not only are there two people engaged in two roles, a reciprocal interaction, but that changes over time as they change. That I don't think we have a great science for. It exists in the physical sciences. I don't know if there are parallels that will pull into what we do that talk about dramatically changing physical systems. I don't know if we'll be able to develop that or if it's applicable, because we don't want to steal methods from other sciences. That hasn't really served us particularly well. We want to develop our own social science. But the agenda itself, we can approach. How it gets fulfilled, I don't know, except that pursuing the agenda where we try to pretend we're like medicine and they have diseases and we treat those hasn't worked out. That we try to treat the average client with the average treatment by the average therapist hasn't really yielded what clinicians actually want. And we've lost the uniqueness of the person when we do that. So we're advocating for a science of human behavior, behavior research methodology. And I do think the umbrella of clinical behavior analysis has the promise to fulfill that. I don't know exactly how it'll look. Where my head goes is it looks something like the weirdness of predicting quanta in an entanglement theory. And I know that's a metaphor because what's going on with quantum particles is different than what we do, but we talk about these sort of inherent sustained probabilities. And we don't know what's going to happen until it happens. Mm-hmm. But we can talk about those probabilities.
Yeah.
Are you still there?
I hear. Can you hear me?
Yeah, your image is frozen, but I can hear you just fine.
Well, I was thinking, yeah, in one side, this returning to the single case design as they mentioned, because we need to grab some of the complexities, and if we have tons of people in a trial, it's not going to be easy to do. And at the same time, I'm thinking about all these longitudinal intensive methods for checking at changes inside of the session, making changes outside of the session for the clients, and changes inside of supervision, making changes inside of therapy. And I think that that's been one of the hardest part of working with FAP, because one of the critics that we have for a long time was our focus on single case designs. And in some ways, I feel in the last 5 years, like, oh, we have the reason for working on single case designs, and you
Right.
are coming back, and it's still struggling with capturing that mechanisms and that dynamics. So yeah, I think that is a hard effort that FAB researchers we have to do, of sitting together and trying to find a good method for
I think
finding out.
so. And I think it's going to be full of compromises. I think it's that we don't have to just drop into RCT design, randomized controlled trial design, and figure like that's going to at least get people to listen to us. And instead, we think like, well, what would I be satisfied with for this client if I could show some change? For me, it's something like, well, let me broadly categorize the behavior, see if the client and I can kind of agree on those targets, and then specify those. And then, in as much as we can, document a shift in those over time. And those kinds of compromises at that larger level, I think, are what cognitive behavior therapists use when they talk about, are you less sad over time? Like, nobody knows. They just know whether the client reports being less sad. And ideally that corresponds, but nobody knows if a schema changed. They just know whether the client says they used a schema change strategy. And people are really satisfied with that. And I'm actually fine with that. I know that we can't probably fully know it. And so, well, what did you try to track and what can you show me? And so if we ask the client, did you try to recognize the situation when you were about to, for example, ask for what you needed? And when you did that, did you try to engage in that different ways? Or, what happened afterwards? How did the person respond? And if we use consistent language, we can actually start to show, I think, general shifts in those behaviors for the client. We can start to group together, well, here's what happens when we do work with clients who, have assertion of needs problems, or in general, if they're working on, all 5 classes versus 3 classes or something. And so we move towards these compromises. Ideally, I think we still, it's a functional assessment. We're trying to get at this specificity that it is dynamic and it's interactive. But we basically talk to ourselves in this incredible precise way of an idiographic conceptualization and functional assessment and a functional analytic intervention. But then we talk to the world using kind of the compromises they've come to accept that are just fine, but without forcing ourselves into an RCT or something like that, which I think we're not going to fit that. Those aren't built around idiographic conceptualizations, as far as I know. And so I think it's doable, but it is going to require an awful lot of thought. But that's okay. People made up those methods. They made them up because they weren't sure how to do things, or they borrowed them from other sciences. And so we can then take it upon ourselves, say we're part of the front end of a new science of behaviorism. Clinical behavior analysis is a hot mess. And so we're part of this, and we can, I think, help initiate ideas of a science that tries to approximate incredibly difficult things to assess and measure as they occur in the natural world, right? Like studying the actual spread of viruses in the real world is a terribly difficult thing. Studying them in a laboratory inside petri dishes is much more focused and valuable. But what the world actually kind of wants to know is, how do they actually move in the world? And so I think that's what we want. We want to have our eye on the prize of, like, we're studying a natural phenomenon, a very complex thing. How can we talk with some precision about this? How can we demonstrate some of this that might be useful, but continue to try to focus on what's really happening here? Those are my thoughts anyway.
Yeah. Thank you, Glenn. It's complex, and I think that we are looking forward to seeing what happened with FAB and IBT and all the progress in this area, because it's kind of worry, but it's exciting at the same.
Live streaming is on.
Oops.
It's on again. Okay, I'm sorry, I didn't know what happened. Can you hear me?
No worries, I can hear you just fine. Yeah.
Okay, it's working again. So I just was going to close this session and thank you a lot for this amazing and, I don't know, like, enjoying conversation about FAB and about IBT as this way of returning back to the principles and seeing FAB in a more like comprehensive way, not just looking at certain kind of behaviors, but all the dynamics that happen within the session and transform the repertoire. So I think that is an exciting moment for the science, for clinical behavior analysis, and I think that the work that you are gonna do is in the center. So thank you so much. I hope that the audience enjoying it, and well, we're looking for a new seminar in the coming weeks. Bye,
Thank
everyone.
you so much. Thank you.